inflammatory bowel disease. Okay, so let's start it. We can wait for a while for us so that rest of the people can join. I'll just put the message. Okay, so yes. So till now, what we discussed about the common GIT disorder. Among that, we discussed what ulcerative dyspepsia and non-ulcerative dyspepsia. Now it's time to discuss irritable bowel syndrome. Okay, what is irritable bowel syndrome? Let's discuss that. IBS, that is irritable bowel syndrome. Now, this is basically a functional. What is it? It's a functional GI disorder which is characterized by chronic or recurrent abdominal pain or discomfort. Plus with this, what will happen? There will be altered bowel habits. Altered bowel habits. So let me clear that although there was pain and discomfort, nausea, bloating in ulcerative, in dyspepsia, isn't it? But over here, one thing which is important is we have to mark that it will also have altered bowel habits. I discussed that when we'll be discussing visceral hypersensitivity, it will be clear very well. Okay, so, IBS is what? It's nothing but a functional GI disorder which can be characterized by chronic or recurrent abdominal pain or discomfort with altered bowel habits. Now, what are altered bowel habits? I hope that we know what are altered bowel habits. So, altered bowel habits can be either diarrhea or constipation or both of them, isn't it? It can be diarrhea, it can be constipation, or both of them. But one main thing that we are missing, what is it? That all of this thing will be there, but with the absence of structural or biochemical abnormalities. Okay, so all of this will be there, but with the absence of structural or biochemical abnormalities. Okay, so I hope now the definition is clear. I'll repeat it again that IBS, that is irritable bowel syndrome, is nothing but a functional GI disorder which is characterized by chronic or recurrent abdominal discomfort or pain with altered bowel habits such as diarrhea, constipation, or maybe both, in the absence of structural or biochemical abnormalities. I hope that it's clear. Okay, so basically, simply what we are going to see. Okay, if there is IBS, then what things can be there? So first of all, there can be pain. Okay, fine. What else? There can be altered bowel habits. Okay, fine. And what else? There will be no structural involvement. Okay, so now let's move forward. So what are the causes? Let's see. Like whenever we study Nidana, we study the Nidana and the Samprapti, right? So here also we'll be seeing the causes of it. So again, these poor modern people don't know the exact cause of the disease. And what they say that it can be multifactorial. What they say that it can be multifactorial because the exact cause is unknown. The exact cause is unknown yet. Okay, so it can be what? It can be multifactorial. factorial. Now, what are these factors? So, these factors are the gut brain axis disordered. If the gut brain axis is not working properly, now how it now yeah, if it is not working properly. Second, either visceral hypersensitivity. What it is, we will discuss in detail. Don't worry. Visceral hypersensitivity. Then altered GI motility. What is it? We will discuss. Don't worry. Okay. Then any psychological factor such as stress, anxiety, depression, isn't it? So these are the factors which can cause what? Irritable bowel syndrome. They say either one of it or multiple of it. Why? Because the exact cause is unknown. Now, what is disordered uh, gut brain axis? Definitely the nervous system is involved and all of that. We don't need to go in detail of this gut brain axis dysregulation. But a very interesting part is that I would like to discuss is visceral hypersensitivity. Visceral hypersensitivity. Sensitivity. Now, what is visceral hypersensitivity? Now, let's see that this is, let's suppose, our lumen. Okay, this is the lumen. Okay, this is a bowl. This is a lumen. Now, let's suppose the person took bread or the person took biscuits which were having carbohydrates mainly, or chapati or something. Okay, the person took that. Now that will be there in the stomach. Okay, this is the carbohydrate. Now what happens? This carbohydrate has a feature. What? It will increase H2O to the stomach. It will take the H2O and it will put the H2O into the lumen, not the stomach, sorry, into the lumen over here. Okay, so what happened? This person took carbohydrates, this person took carbohydrates, and now this carbohydrate is absorbing water into the lumen. Now this water needs some space to go, right? So it will start stretching this wall. What it will do? It will start stretching the wall. Once it stretches the wall, now what happens over here? Again, the nervous system, this will go and say the brain that, now let's suppose this is a brain. Okay, so this is the brain, CNS. Now, when this goes and tells that, oh, see, some stretching is happening over here. Now, due to, if let's suppose, as they said, what? It can be multifactorial. The first factor is what? The eating habit, the carbohydrates and blah, blah, blah. The person took over here, bread, etc., etc. So now that carbohydrate has done what? Taken water into the lumen. This lumen, water has started stretching the lumen, and now this signal has been sent to the brain. Now, if there is involvement of any psychiatric disorder, it can be any stress, anxiety, or anything, then what happens? The brain will amplify the stretch. The brain will say, oh, there is more stretch. Oh, there is more pain, so there will be more abdominal, the abdominal pain will be more. Okay, the abdominal pain will be more. So this is one of the example of visceral hypersensitivity. Okay, I hope that it's clear what is visceral hypersensitivity. That whenever the person is taking carbohydrates, this carbohydrate is doing what? It is increasing water into the lumen. This water is doing what? It is stretching the lumen. This stretch receptors are taking the signal to the brain. Now the brain, because there is a psychiatric disorder, now brain is amplifying the pain and saying, oh ho ho, no, your pain is not less, your pain is too much. And then the person feels too much of pain. I hope it's clear. Okay, so now another part, we discussed another reason. It can be what? Hypermotility. Now, what is that? We will see that. I hope that it's clear. It's clear that what is visceral hypersensitivity, and you never know. Actually, this modern people don't know what is the factor, what exactly is causing this pain. But they have an example that if let's suppose carbohydrate and blah 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 is taken, water is there, then stretching is there, and then pain will be there. Okay, so this is that. The another reason that they explain is hypermotility. What they explain? They explain hypermotility. So this is hypermotility. Motility. Okay. Now what is hypermotility? Again, let's imagine you have a gut. This is the lumen. Okay, these are the smooth muscles. Okay, now what they say, they say that let's suppose any food particle is there, not only carbohydrates, any food particle. Now when this food particle is doing what, either it can be carbohydrate or any food particle, again it's doing what, it is producing, it is absorbing the water, or maybe due to any reason it is stretching the lumen, it is stretching the lumen, and not only stretching but it is having a reflex contraction that we call as spasm, reflex contraction or spasm, mild contraction is there, and due to any reason what is happening, this signal is going to the brain, or other receptors over here, and then this is enhanced, and what happens, this gets enhanced, then what happens, the motility increases, the motility of the gut increases, and once the motility increases, and when it is abnormal, sometimes it will be increasing, sometimes it will be decreasing, there we see multiple types of IBS, that is IBS-D, IBS-C, or maybe IBS-M. What is this? Let's see. So, either it can be inflammatory bowel syndrome with diarrhea, or it can be with constipation, or it can be mixed, both. Actually, there is one other category also, and it is D. Sorry, where they say that we don't know what will happen, but something will happen, and it will be due to hypermotility itself. Okay, so this is all about hypermotility. Now, one thing that we have to mark over here is that over here there is not only pain, but with pain the person will also have what, diarrhea or constipation. But if we are talking about this visceral hypersensitivity, what was there, only pain was there. Okay, now the other part, that is another explanation for why IBS happens and what is the pathophysio of IBS. So the another explanation says that, let's suppose because of altered microbiome, you're, maybe you are taking anything because of which, let's suppose you're taking this frequently, people are used to take antibiotics. Okay, one of the reason, another reason, taking multivitamins for no reason, because they think, oh, it is good, they're taking multivitamins. Now what this is going to do, again it is going to affect for no reason. If they are taking, let's suppose the bacteria in the gut, what happened, they flourished or they have started acting like abnormally, what will happen, now this person who have altered the microbiome, again what will happen, this carbohydrate, isn't it, again the carbohydrate, what will happen, this bacteria is now more efficient to break down or digest this carbohydrate. When the carbohydrate breaks, what happens, there is secretion of it, it will be broken down into what, it will be broken down into H2O as well as CO2, isn't it? So this bacteria of this person is now more efficient. Let's suppose in you the bacteria was able to digest carbohydrate up to a limit of 5. Now in this particular person, this bacteria has doubled the function, and now it is able to digest the carbohydrate up to a level of 10. Okay, so then what will happen, H2O is going to increase and CO2 is going to increase, definitely gastritis issues will be there. Then of course when carbohydrate is there, again water will come into the lumen, it will stretch, then the stretch receptors will go to the CNS, the CNS will say, oh, because you are, it's not only mild pain, it's a more, like you're having more pain. So in altered microbiome, gastritis will be there, or maybe pain involvement can be there. So these are the pathophysiology of what? Irritable bowel syndrome. I will repeat. What is irritable bowel syndrome? It's nothing but a functional GI disorder. Functional GI disorder. There is no involvement of structural or biochemical abnormality. Okay, now what happens? It is characterized by chronic, or it can be reoccurrent. What will be there? There will be abdominal pain or discomfort, as well as there will be altered bowel habits other than dyspepsia. Okay, so this was all about the pathophysio of irritable bowel syndrome. Now let's see, if the patient comes to you, what all complaints the patient is going to tell, that what all things he's going through, he or her. Okay, so the clinical features that you may be seeing in your patient, the clinical features can be what, definitely we saw pain. there will be pain or discomfort, isn't it? First of all, the patient will say, oh, I have abdominal pain, oh, I have some discomfort. Then they will tell, oh, sometimes it's constipated, oh, sometimes it's diarrhea, or sometimes he'll say, oh, for it is constipated for a very long time. Okay, others other reasons, what else can be there? Altered bowel habit. Other reason, there can be blotting. If blotting is there, definitely flatulence can be there, and there will be feeling of what? Incomplete evacuation also in certain cases. So when your patient comes and say, oh, I have stomach pain, doctor, I have some discomfort, I have, my bowel habit is not normal, it is something weird happening there, and then they will say, oh, blotting flatulence is there, or I am feeling that my potty is not going out completely. Okay, so these are the features that a typical IBS patient will tell you. Okay, now how we are going to diagnose this irritable bowel syndrome? Let's see the diagnosis part of it. Okay, how we are going to diagnose it. So there is a criteria called Rome 4 criteria that we already discussed, isn't it? Rome 4 criteria. The typical one for IBS is it should be related to, it should be related to defecation. First of all, it should be related to defecation. Don't confuse, because in dyspepsia, we all, although we talk about that stool color and frequencies, all of that, but it is mostly the pain was the symptom. Over here, the bowel is having the alteration and all. Okay, so it will be related to defecation. Second part, there will be change in stool frequency. Change in stool frequency. The third thing will be change in stool appearance. These are the three features. If you get, you can diagnose this condition as what? As irritable bowel syndrome. Okay, we can diagnose this condition as irritable bowel syndrome. So this was all about irritable bowel syndrome. I would like to repeat it once. If I'm very fast, please let me know. Like if you're not able to follow me, please let me know. Okay, so I'll just repeat once, because there are people who came late. So let's repeat it. Let's give a quick review on what all we discussed till now. So till now we discussed about irritable bowel syndrome. We said it's nothing but a functional disorder where we can see abdominal pain and discomfort, we can see altered bowel habits, but definitely there will be no structural or biochemical abnormality. What are the causes? They say the gut brain axis will be affected. They say there will be visceral hypersensitivity. They say there can be hypermotility or altered microbiome. Then we saw visceral. What is visceral hypersensitivity? We saw when the carbohydrate is there, what happens? It absorbs H2O to the lumen, then this lumen will stretch, and then the stretch receptor will do what? There will be pain. Hypermotility, again there will be motility due to some of the factor, any food. So what will happen over here? Over here, pain with diarrhea or constipation, or maybe mixed. Then altered bichrome was sorry microbiome was doing what? It was increasing H2O and CO2. What were the clinical features? Pain, discomfort, altered bowel habits, blotting, flatulence, or it can be what? Incomplete evacuation of the feces. Then what Rome 4 criteria we discussed for diagnosis? These 3 points, these are the major important points. What are it? Related to defecation, there should be change in the stool frequency and change in the stool appearance. Okay, so this was all about IBS. Now the second topic that we are going to discuss, and the last topic for today's uh, session, is IBD, that is inflammatory inflammatory bowel disease. Okay, I hope that it's clear that irritable bowel syndrome. Now we'll be moving on towards inflammatory bowel disease. Now what is inflammatory bowel disease? Let's see that. Just give me a while. Okay, so let's start inflammatory bowel disease. What is inflammatory bowel disease? Chronic, it is a chronic Relapsing, chronic relapsing or recurrent, whatever we say, inflammatory disorder. Okay, what it is? It is a chronic relapsing inflammatory disorder. Okay, it can be of two types, either ulcerative colitis or Crohn's disease. This question was asked, I guess, in our term exam, and they asked us to write the difference between ulcerative colitis and Crohn's disease. So we'll see what is it and what are the typical features of both of them. So I'll try to finish it within this session because this class will again end within 15 minutes, I guess. Okay, so now let's see what is ulcerative colitis and what is Crohn's disease. So we will be studying this in a comparative manner. Okay, so see, ulcerative colitis. Ulcerative colitis. Okay, let's see first what is ulcerative colitis. See, ulcerative colitis, in this, what will happen? Let's suppose that this is your colon. See, ulcerative, we already discussed that meaning of the term ulcer, isn't it? Ulcer term, we already know what is ulcer. Now we also know what is colitis, isn't it? We know the meaning of the term colitis, what it is. It is definitely related to colon. There is inflammation in the colon. So definitely ulcerative colitis is what? Inflammation in the colon. So let's suppose that this is a colon. Okay. Okay, now this is the colon. Now, what happens in ulcerative colitis? Mostly it occurs in two parts, two regions you can see mostly, that is the colon or in the rectum. Just remember that. Okay, two regions it will be there, colon or rectum. Now, what is it? It is just mark this point very well because this creates a difference between ulcerative colitis and Crohn's disease. What it is? It is a continuous. It is a, let me write it down. Yes, it is a continu it is a continuous mucosal inflammation. Now what does that mean? So we know this gut, we know this is our colon. Now this colon is having this, what it is having, it is having mucosal lining, right? So this is the mucosal lining of the colon. Now, in this mucosal lining, this beautiful lining is there for the protection. Okay. Now, what happens is there will be inflammation seen. There will be inflammation seen. Now, how this inflammation is seen? Let's suppose this will be continuous inflammation. Like let's suppose here in the colon there is continuous inflammation. Okay, this inflammation will be continuous. Either in the rectum part there will be continuous inflammation. Okay, so when the inflammation is continuous, it is what it is. It is when it happens in ulcerative colitis. Okay, I hope that it's clear that what is ulcerative colitis. Okay, now what happens in now we'll see what happens over here in case of Crohn's disease. Okay, so this, yeah, again in Crohn's disease, what happens now? Another thing is Crohn's disease. Crohn's disease. Now, what happens in Crohn's disease is, let's suppose this is your GI tract. Okay. Now, it can happen anywhere in your GI tract, not necessarily in the colon. Okay, not necessarily in the colon. It can happen any part, in any part. Okay, but mostly it is seen where? In the ilio. Mark this point. Mostly where? Mostly in the iliocecal junction. Mostly seen, but can be seen anywhere. Okay, so what happens? Another important point. What happens in this? In it, like I hope that it's clear that it can happen anywhere in GIT. Okay, and now what happens? There will be transmural transmural segmental inflammation. Now what it is? Now what does that mean? So let's see what does that mean. So let's suppose again this is, I'll take the colon again. Why? Because it can happen in colon, because it can happen anywhere, isn't it? So let's suppose this is our colon again. This is the colon I have taken. Now again beautifully. What was arranged? The mucosal layer was arranged beautifully over here. अरे यार. Hmm. It was arranged. Okay. So it's arranged over here. This mucosal layer. This has been arranged. Now, what happened? Now the inflammation will happen. But what kind of inflammation? First of all, it will be transmural. It means it is going to produce some sort of cleavages in the this layer. What it is, how it is, we will discuss. Don't worry. Okay. So over here, what will happen now? This inflammation, this particular inflammation will be segmental. Let's suppose this part is having inflammation, then this part will have inflammation. Then this part will have inflammation, then this part will have inflammation. So I hope that you can see a clear difference between ulcerative colitis and Crohn's disease. Here, over here in ulcerative colitis, it was continuous mucosal inflammation, whereas in Crohn's disease, it is transmural segmental inflammation. In ulcerative colitis, it could be either in colon or rectum. Here it is any part of the GIT, but mostly in ileocecal junction. Okay, I hope it's clear. Now, another point of discussion, what it can be? It can be that ये बंद क्यों हो जाता है? Another point is when we see the section of this lumen in ulcerative colitis, what will happen is that it will be the lumen will be dilated. The lumen will be dilated, and that's why we call it as garden horse appearance, okay, or pipe stem appearance. Whereas in case of this Crohn's disease, what happens? There will be inflammation, there will be swelling of this lumen, but it will be outside, and the lumen will get what? The swelling will be out, but the lumen will be what? It will be narrow. The lumen will be narrow. That's why we call it as what? Horse pipe appearance. Horse pipe appearance. Okay, so this is the another difference when we see the C section of both Crohn's and ulcerative colitis. Okay, now another difference is what? In ulcerative colitis, there will be superficial ulcers will be present. Superficial ulcers means what? That let's suppose this is the layer mucosa, submucosa, so then muscular, then the serosa, isn't it? So this inflammation or the ulcer will be present where? It will be present up to here only. Okay, here, up to here. The ulcers will be up to the mucosal layer. Okay, it will be disturbing most up to here. Okay, whereas if we talk about whom? Crohn's, then it will be serpent. They use the term serpentigenous ulcer. Now what does serpentigenous ulcer mean? Again, mucosa, submucosa, muscularis, and serosa. Sorry, uh serosa. Okay, so over here again, what will happen? The ulcer will be deep. This ulcer will be deep. Maybe it is affecting more than 2 to 3 layer, and sometimes it also have bleeding because it is affecting so much. So this ulcer is what is ulcer? I hope all of you remember what is ulcer. It is shedding off of the cells, isn't it? It means it is creating a gap over here. It is creating a gap over here. Okay, so a gap will be created over there. So this is the kind of ulcer formed in where? In the Crohn's disease. Okay, and another thing which we have to remember is that it has cobblestone appearance. What is cobblestone appearance? Now let's suppose that there are two layers. Okay, now if these two layers have gone down, it has just gone down, then what will happen? This part will be appearing what? Elevated, isn't it? If these two parts are getting depressed, then this part will be looking elevated. So this part is getting depressed, and this is getting elevated, so it seems like a stone. So that's why it's called cobblestone appearance. So this is about the condition of ulcerative colitis and Crohn's disease. We'll see what are the difference in the clinical features now. Okay, so let's see the difference between the clinical features. Okay, so Okay. So, in clinical features, in ulcerative colitis, bloody diarrhea is possible. What is possible? Bloody diarrhea is possible. Whereas in bloody diarrhea is just I'll write bloody diarrhea is possible. Lower abdominal pain will be there. Lower abdominal pain will be there. Third, what disease will be limited to the colon. Disease will be limited to the colon. Whereas if I talk about Crohn's disease, there can be chronic diarrhea like condition. There will be definitely abdominal pain will be there. What else? Fever can be there because the inflammation is too high, right? As well as weight loss can be seen in the patient. Okay, now what are the clinical examination that can be done? So the clinical examination can be, first of all, pallor will be there. Why? Because definitely anemia will be there if the blood is coming in the stool, isn't it? As well as tenderness will be there. Tenderness in the abdominal region. This thing will be there. And there are certain signs of complications seen in Crohn's disease. What are those? Those are perianal perianal fistula and abdominal distension. Why it happens? Because see, over here only the space is getting created, isn't it? And fistulas are what? There are spaces gets created, so that's why it is seen where in Crohn's disease as a complication in Crohn's disease. So I'll just repeat what we discussed till now. We discussed about what? About the IBD, that is inflammatory bowel disease. In that, two main diseases are there. They are the ulcerative colitis and Crohn's disease. Ulcerative colitis is what? There is continuous mucosal inflammation. So, and it happens where? Mainly it will happen in the colon or it will happen in the rectum, isn't it? Another thing that we discussed about Crohn's, that it can happen anywhere in the GIT, mostly in ileocecal junction. And what it is transmural segmental inflammation. Then we talk about the lumen. Lumen will be dilated in ulcerative colitis, but it will be lumen will be narrower in what? Crohn's disease. Again, the ulcer is superficial in ulcerative colitis, whereas it is serpentigenous or cobblestone appearance in what? In the Crohn's disease. Whereas if we talk about the clinical features, there is bloody diarrhea in ulcerative colitis, there is lower abdominal pain, or there is disease limited to colon. Okay, whereas if we talk about Crohn's disease, there is chronic diarrhea, abdominal pain, fever, weight loss, etc. Examination can be done by, of course, there will be bleeding, there will be loss of blood, so the patient will be anemic, so pallor will be there, tenderness over the abdominal region will be there, and complications in Crohn's disease mainly are perianal fistula and abdominal distension. So in today's session, in this pathology section, we discussed about the common GIT disorders, and we have discussed that how there can be multiple disorders, but among them today we discussed the four, that is ulcerative dyspepsia, non-ulcerative dyspepsia, inflammatory bowel disease, and irritable bowel syndrome. So I will stop the session over here. We because for today we have completed the topics or the aim which we took for this pathology. Okay, thank you so much.